This is Crisis Point.
Survey data has suggested that most people really value their sense of sight, often more than other recognized senses, including touch, taste, and smell. But like many aspects of public health in the United States, there are disparities affecting eye care, impacting our most vulnerable populations and keeping equitable health just out of reach.
From those with housing insecurity lacking access to eyeglasses, to the high prevalence of eye diseases among minority populations, there seemingly remains a lot of work still to be done.
So with glaucoma, it is a progressive disease, and it's something that we have seen can be at least, slowed down, if not, significantly stopped in its progression just by managing it with medical care, sometimes surgical care if necessary. But everything starts with identifying the disease and monitoring the progression and adjusting the treatment as necessary. In patients that may not realize that they have it, especially with glaucoma, where it is a slowly progressive disease that starts at the periphery of their vision and kind of moves inward, a lot of patients will not even notice that they're losing their vision until it's too late. And so it's really important that we are screening for it and catching it before it starts to really inhibit their daily life. Some people, for various reasons, aren't able to make it to an eye specialist, whether that be the distance to their nearest ophthalmologist or even optometrist, their ability to take off work, their ability to get childcare. There are so many issues of access within getting that patient to that appointment. And so things like community screening programs that can either target building relationships with certain communities or bringing that program in a closer to the community that it's trying to help can help and mitigate these access barriers. I think that just goes a long way with not only building relationships with them, but also, addressing these healthcare disparities and improving the relationships with the community at large, so that they know that they can trust in their healthcare providers to look out for these communities that, again, are just traditionally underserved in medicine. What really sets apart this study from what's previously been done is the ability to use the NIH All of Us database. This database is phenomenal, and it's great because it is trying to enroll 1 million Americans, focusing specifically on trying to enroll those patient populations that are traditionally underrepresented in research. And that can mean, racial minorities and ethnic minorities, but also patients who, are uninsured or come from lower socioeconomic, status, ones that are just traditionally not able to participate in these studies. And so by enrolling this population, we are able to get a better understanding of how these socioeconomic factors can contribute to overall health disparities.
We're currently conducting a program based in a federally qualified health center and a free clinic, where the purpose of the program is to detect eye disease at higher levels than one might get bringing every single person in America into the eye doctor. And the reason that we placed these kind of telemedicine-based programs in a free clinic and a federally qualified health center is because those clinics already serve communities with high burden of disease because of lots of reasons. And a lot of those are really tied up in what we found in our research and our experience working in these communities and asking people if they need to be referred to a food bank or if they need to be referred to social work for problems with housing, and if they need additional help with insurance or transportation. All of these things are huge barriers to having follow-up eye care coming into the system to begin with.
There's this gap in the use of diagnosis codes. And so when we created our cohort, we pulled the patients by specifically pulling those ICD, diagnosis codes that are associated with glaucoma, and then different levels of glaucoma from mild, moderate, or severe. And then the analysis we ran different stages against each other, but there was a significant number of patients that didn't have a stage. They were diagnosed with primary glaucoma of some kind, but they weren't assigned a stage of disease. So we have no way of knowing how severe their disease was. What that means is that 57% of our glaucoma patients were essentially removed from the analysis. We looked at this 57% who were missing, and they would traditionally they came from traditionally underrepresented groups. They came, from patients that were from lower socioeconomic classes. They came from, Latino and Hispanic populations, just from those populations that we tend to see face health disparities in medicine. And so that's a huge thing to know, that, more than half of our patients are, one, missing, but then also it might be overly representative of the patients that are more likely to be experiencing health disparities.
Talking with people at the free clinic and at the federally qualified health center was how we kind of implemented the program, using people's 2 cents on how they wanted it to be. And people wanted it to be accessible. So they wanted it to be available when the clinic was open, not just kind of like a mobile van where it comes in every now and again and shows up and then goes away, but something where it could give people more flexibility and options regarding when they could come in for appointment times. And people gave us great ideas about how to engage people in the community in coming in to get eye disease screening and to get glasses. And all of those ideas and all of those voices really helped us to bring a lot of people in. Half of the people who came, who are coming to this program, hadn't had an eye exam in at least 2 years. The Hope Clinic, which is the free clinic that we've been working with, is wonderful and really tries to tailor their food pantry to people with various medical needs. And there's a food pharmacy in Flint, Michigan, that also tries to do the same thing. So when we've been asking these questions and ascertaining the issues that people are facing, we try to also plug them in to the Band-Aids that exist in the United States, such as food pantries, to try and access help. When you have high burdens of poverty and you have lots of conflicting needs, like not sure, when if you're going to have, healthy food to eat, or if you're going to have enough food to eat, or if you're going to be able to feed your family the way you really want to, or you're worried about your housing, these are things that take precedence over coming in for an eye exam.
In these analyses, both individuals from traditionally underrepresented groups in medicine and those underprivileged in society dealt with difficulties in receiving eye care. As the investigators suggest, these patients remain at the greatest risk of poorer outcomes and worsening health as a result of these large gaps in care.
We found that all racial and ethnic minorities were diagnosed with glaucoma at younger ages. And this is concerning just because, we're seeing that despite the fact that they may not have all shown more severe disease, they're being diagnosed at earlier ages. That's a greater risk for progression. There's something leading to them developing glaucoma at an earlier age. And so this is just one of the things that we want to keep an eye on. We want to continue to look at. Are there barriers that are causing them to progress more rapidly than their counterparts? Are there biological reasons that they may be developing glaucoma at an earlier age? Our Black African American patients also had more severe disease. In previous studies, this has been shown, but we haven't really been able to decipher whether that's due to social factors, whether that's due to physiologic reasons, or a combination of the two. And so in doing the study, one of the things we wanted to see is whether controlling for those socioeconomic factors would in fact eliminate that discrepancy. And it didn't.
I don't think our findings were really so surprising that people with unstable housing were walking around with visual impairment at much higher rates than people with stable housing, and that most of that was just from not having glasses. And in this day and age, when you can get glasses, at an online optical source for $12 to $35, that seems like a real sad situation for a country that has as many resources as ours does. So we look to see whether food insecurity and housing insecurity were related to either presenting with visual impairment or presenting with any of the 5 leading causes of blindness and visual impairment, which includes uncorrected refractive error, cataract, diabetic retinopathy, glaucoma, macular degeneration. And we didn't find any specific associations between any of the diagnoses, any of the pathologies, and food or housing insecurity. But we did find that people who were housing insecure were much more likely, I think it was like 250% more likely to have uncorrected refractive error due to not having glasses. And then we also saw that those people who had diabetes were more likely to be food insecure but we did not find any relationship with diabetic retinopathy and food insecurity.
Improvements to gaps in care could ultimately alleviate a clinician's workload and benefit patient outcomes. Taking a more centralized approach to EHR systems and the collection of real-world data outside of clinical trials could be important first steps to improve clinical practice.
They have, a lot of patients in their clinic that they're trying to see in a day. They really don't get a whole lot of time with their patients. And so in between doing a full exam, getting their history from them, talking through their treatment options, they're also making a lot of clicks inside of the electronic health record system and adding things like making it more difficult to find the severity stage or to, specify exactly all the characteristics of the disease as you're putting it in the diagnosis, are just additional barriers that a physician may not have time to address within that small period of time that they have with their patient. And so that leads to things like we see in our study where people are not putting severity staging in the diagnosis codes, or, just sometimes not even fully putting in all the information that they need to. And it comes down to just a lot of things that need to get done specifically for billing, and not so much for the patient care aspect of things. But yeah, as of right now, because, EHR databases are consistently, continuing to improve and continuing to find ways to streamline the process, it is still a work in progress. We have to look at the ways that it is maybe not aiding in our ability to accurately document our patient encounters.
There have been some reports, other studies that have been presented at previous ASRS meetings showing that if you apply the clinical trial inclusion and exclusion criteria to our real clinics, only 50% of the patients for a certain indication like neovascular AMD, for example, would actually qualify for a clinical trial. So what happens with those other 50% of patients? We have no real guidance as to how those patients would behave. So looking at real world data really helps to fill in that gap about what's happening to patients who have these indications but may not have qualified for a trial. Of course, there's limitations to any real world study. The visual acuity isn't garnered in, as exacting protocol-driven manner as you would in a trial. And, we don't have any sort of insight into the physician's decision-making process as to why they're being switched or why they're being extended and so forth. So, there are limitations to real-world data, but I think, the upside, I think certainly is important to really fill in those gaps.
Still, it remains to be seen how these issues will be addressed on a large scale and who the involved players will be. Community programs and the improved use of EHR databases may be just the beginning, and policy may be the best way to improve eye health outcomes.
I think this is a public push that just really delineates on a granular level and at an eye care level what are the impacts of extreme poverty. And the proportions of poverty in our country are only increasing, and the proportions of extreme wealth are only increasing. So I think this really calls light on the fact that we need policy level solutions to address income inequality. And these could range from things as simple as increasing the minimum wage to a living wage. It could be making sure that all places have access to really high quality public transportation. It could be mandating, that doctors' appointments are okay, as part of labor negotiations. There's many policy changes that need to be enacted in order to try to move the U.S. out of this space where there's such inequality and people who are living with limited means. That means that their health outcomes are really poor, including their eye health outcomes. If you place, kind of eye disease detection and glasses dispensing programs in homeless shelters, you could, perhaps take that away as one potential intervention. You could also take away, there's federally qualified health centers. One of their missions is to serve the homeless. So ensuring that there's high quality and widespread access to eye care through federally qualified health centers that already serve medically underserved communities could be another kind of policy program. And I would say that I could see happening in my lifetime and hope that it will.
coming from an underrepresented community and a community that traditionally faces some of these degenerative diseases at a higher rate than others. It's really important that we continue to work with all members of our community to make sure that everybody is getting equitable care, and really recognize those places where we can do better to build community relationships, and also just to essentially improve the way that we are delivering care. Ophthalmology is this very rapidly growing field, rapidly developing field, which makes it so exciting. But in the meantime, we need to make sure that we're not leaving people behind. And so looking at ways that we can improve the use of EHR databases to be mutually beneficial, not only to our administration and the people who work within billing, but also to help the physician-patient relationship, to make sure we're accurately documenting things so that we can use this data not only to improve patient care and accurately monitor our patients, but also so that we can continue studies like this, looking at these disparities, making sure we're getting accurate data that allows us to really track how our patients are doing.
I think people value their vision tremendously. I mean, there was a recent survey a few years ago about, how much do people value their vision compared to other kind of health issues that they might have, and people valued vision way up at the top. On the one hand, I think that's really important to understand that people place high value on their vision, and on the other hand, there's a limited pie, at least the way it's currently set up. And you don't want to say, well, you shouldn't give money to diabetes because you should be giving it to eye care, or you shouldn't give money to address food insecurity. You should be giving it to eye care. So I think the problem is that we have set up in this country a scarcity mindset where the pie is very limited, though the resources are abundant. So if we changed our mindset and started thinking about the extreme resources and wealth that we have in this country, and think about ways that that could be tapped into to ensure that people at least are, living in the lower socioeconomic status strata with, still a good life. You have a house, you have glasses if you need them, you have access to healthy food when you need it. Maybe you don't need to drive a Rolls Royce, but the regular things are taken care of. So I don't know that will change in my lifetime, but I hope by writing all of these things all of the time that people start to feel like policy could change. It doesn't need to look this way. We have a large pie in America, and we could raise the bar for everybody.
This has been HCP Live Crisis Point. Thank you for watching.